Welcome back to our instructional masterclass series. Today, we're decoding the absolute foundation of government payers by breaking down Medicare Parts A and B. Look, as an expert medical billing educator, I can tell you straight up, if you want to succeed in the revenue cycle, you have to understand the rulebook of the nation's chief government payer. This explainer is designed to give you that exact edge. Let's get right to it.
Here's our roadmap for mastering the strict operational rules, funding mechanics, and common billing traps every healthcare professional must know. We'll hit Medicare origins and funding, Part A inpatient rules, Part B outpatient coverage, the late penalty trap, and finish up with our decoding healthcare summary.
All right, Section 1, Medicare origins and funding.
You really need to know where the money comes from to understand how it flows, right? So Medicare was established back in 1965 as a pivotal part of the Social Security Act. Now, what's really interesting is how Medicare defines who actually gets to carry this card. It's specifically designed to offer health insurance to individuals aged 65 or older. But it doesn't stop there. It also covers individuals under 65 who have a qualifying physical or mental disability. As a biller, knowing this exact demographic is literally your first step in verifying patient eligibility. So, the million-dollar question. How is this massive government program financed? Well, it's funded through FICA payroll levies. Basically, that means there are mandatory payroll taxes contributed equally by both the employee and the employer. It's a shared national investment. And honestly, that's exactly why the billing rules are so heavily regulated. When you submit a claim, you're directly interacting with a federally funded trust. Because Medicare is so comprehensive and, let's face it, a bit of an alphabet soup, it's divided into 4 distinct parts, each with its own unique set of operational rules. You've got Part A for inpatient care, Part B for medical and outpatient services, Part C for Advantage replacement plans, and Part D for prescriptions. For us in the billing and coding world, this means you must meticulously verify the exact active parts on a patient's card before any services are provided. Assuming a patient has full coverage just because they handed you a red, white, and blue card, yeah, that's a one-way ticket to denied claims and a massive headache for everyone involved.
Moving on to Section 2, Part A, Inpatient Rules.
Here's a massive trap that catches a lot of new billers and coders totally off guard. Ask yourself this. If a patient spends the night in a hospital bed, eating hospital food, being monitored by hospital nurses, does that automatically qualify as a Part A inpatient claim?
Absolutely not. No way. And this brilliantly illustrates the strict nature of Medicare coding. For the stay to actually be billable to Part A, the patient must be formally admitted as an inpatient under the direct instructions and orders of a physician. If they're just being held for observation, even overnight, that typically falls under outpatient rules. Understanding this distinction is absolutely crucial for proper facility billing.
Section 3, Part B, Outpatient Coverage. If Part A is the hospital bed, Part B is the doctor's office. Part B is the financial assistance program for a really wide scope of services. We're talking your standard physician office visits, outpatient hospital clinic visits, durable medical equipment, and home health care. It also covers critical preventative treatments like your annual flu vaccine. So, if you're billing for a specialist consultation or an outpatient procedure, you're looking squarely at Part B. But here's the catch. Unlike Part A, which most people get premium-free if they've worked long enough, Part B comes with a strict cost-sharing structure. Beneficiaries are required to pay a monthly premium just to keep this coverage active, and they also have to meet an annual deductible before Medicare even starts paying its share.
Crucially for billers, remember this number, 20%. Once that annual deductible is met, patients are liable for a standard 20% coinsurance requirement on all Medicare-covered Part B services. So Medicare pays the 80%, and the patient, or maybe their supplemental insurance, is on the hook for that remaining 20%. Your entire revenue cycle depends on accurately calculating and collecting that exact balance.
All right, Section 4, the late penalty trap. This is where we run into one of the biggest misconceptions in medical billing, which is a major headache for patients. You have to dispel the myth that Part B is automatic. A lot of patients erroneously think that just because they turn 65, boom, they miraculously have full medical coverage for everything. The fact is, Part B is strictly an elective component. Because it requires that monthly premium, beneficiaries actually have to actively choose to enroll. This is precisely why you must physically verify active Part B eligibility on the patient's Medicare card or through your digital portal before rendering any services. There is, however, a permitted deferral process. Beneficiaries can legally defer their Part B enrollment without facing any penalties, but they've got to meet some strict criteria. Step 1, they must remain gainfully employed past age 65. Step 2, they must be actively covered by that employer's group health plan. If they meet those conditions, they can safely defer Part B until that group coverage eventually ends.
But for those who stop working or lack that qualifying group health coverage, missing their initial enrollment window springs a very harsh financial trap. When a patient realizes they need coverage later on and tries to sign up, well, they're in for a shock.
They'll face a mandatory 10% penalty added to their monthly premium for every single year they delayed their enrollment. And get this, it's not just a one-time fine, it's permanently tacked on to their monthly premium for life. Understanding these operational rules not only makes you a better biller, but it really equips you to better understand the immense financial pressures your patients might be facing when they show up at the front desk.
Let's wrap this up with Section 5, Decoding Healthcare Summary. The fundamental distinction you absolutely must remember from this explainer is Part A versus Part B. Part A carries that strict, mandatory, formal inpatient admission requirement. Remember, an overnight stay just doesn't cut it. You need direct physician orders. Part B, on the flip side, is an elective outpatient coverage system that comes with monthly premiums and a strict 20% coinsurance cost-sharing structure. Knowing this difference dictates exactly how you code and bill the encounter.
In our next training module, Part 7, we're going to build right on top of this foundation. We'll decode Medicare Part C, those private advantage replacement plans that basically change all the rules. We'll also cover Part D prescription plans, and we'll dive into Medigap, which are the supplemental policies designed specifically to bridge that 20% cost-sharing gap we talked about today.
Until then, stay focused and always verify those cards up front to avoid those costly billing traps. But I'll leave you with this. What happens to your revenue cycle when a private insurance company completely takes over a patient's Medicare benefits? We'll answer that next time. Like, share, subscribe to Decode Healthcare with Harshal.